And on the symposium, last month, we have all the recordings now online. For those of you who couldn't make it, it was on climate-induced change in maternal and child health. All the talks are recorded. So just want to remind people of that. Okay, and then just a couple other events coming up. In December, we have the 4th biannual 22q11 deletion syndrome symposium. And that is coming up in about a month. And so hope to see y'all out there. And then, as I mentioned, the symposium recordings are up on our website, so please check it out. And also, we put out an annual report every year for MCHRI, and it's a digital format and it's online. So make sure you can check that out. It's every year we put this on our website, and it has all of our highlights for the year, and also all the awards that we give out in the year, and other interesting data and stats that you can check out. And then, of course, the main event for today, we have a really exciting, and I think for the first time, really highlighting our partnership with the Quantitative Sciences Unit that MCHRI has had for many years now. I've actually lost count how many years it has been, but today we have Dr. Maya Mathur with us from the Quantitative Sciences Unit, and she's going to chat a little bit about like the services they provide and a little bit about our partnership. And then Dr. Suzan Carmichael and Dr. David Maahs will share with us a bit about their projects working with a QSU, and then we'll open it up to Q&A. So with that, Dr. Mathur.
Great. Thanks so much, Mary. And it's really a pleasure to be with you all. Hello to everyone who's on Zoom. Good to see you. Oh, there we go. I think the space bar is doing it. Great. So I'm just going to be saying a few words about the Quantitative Sciences Unit and how we partner with investigators within MCHRI, with the hope of inviting you all to join us as collaborators. This is the slide I want, so we're good. So what is QSU, Quantitative Sciences Unit? So we are a team science-based collaborative statistics group within the School of Medicine, which has partnerships with a number of departments and broader groups, MCHRI being one of them. And that's, of course, what we're going to be highlighting today. So our mission is to work with our clinical and translational collaborators to address important biomedical questions by practicing and mentoring in data science. And data science is a broad umbrella that encompasses many different things. So it's we might sort of initially think of maybe data science means kind of turning the EHR into p-values, and that's data science. So no, it's actually a broader endeavor than that. It really starts with thinking through study design and really helping investigators and working collaboratively with you guys to think through what your questions are and how can we design a study that will rigorously address those and allow us to do statistics down the road that will actually answer your questions. Data science also includes database development and management. So how do we store and curate data in line with IRB and HIPAA requirements as necessary, as well as data wrangling. Another focus of the QSU is, in addition to our collaborations, to develop new statistical methods and software when we see that there's some kind of recurring need that our collaborators have. And this is, for us as statisticians, a really fun part of what we do is seeing problems in the wild that you all bring to us and trying to actually develop new methods or software to hopefully solve that problem going forward in the future. And our model is very much one of, I would say, actually mutual mentorship. So we sort of mentor our investigators in data science, in research methods, in interpreting results in a statistically rigorous way. But likewise, we also learn a lot from all of you. We learn about your substantive area in the course of collaborating with you. And so hopefully it gets to be a positive synergy. We also do a lot of mentorship within our own group. So we have data scientists with a broad range of expertise, which I'll touch on later. And so we're always mentoring each other through internal meetings, as well as seminars where we are sharing statistical cutting edge with one another. And so we really think of ourselves as a home for practicing data scientists and team science, where team science really means this endeavor of working together with clinicians where we're mutually learning and both heavily scientifically invested in the research topic. And we're also sort of we see ourselves as a bridge across different medical disciplines because we are fortunate to get to partner with a number of different departments within the School of Medicine. And so we get to sort of have our eyes and our listening ears on from all of these different departments simultaneously. And our group has a variety of different members in it. So we've got staff data scientists who are anywhere from master's level to PhD level. Some are MPH. We've got faculty members, and we have some operational staff as well. And so again, our approach to collaboration is really one of team science, of mutually working together. And we have within our unit a diverse range of phenotypes of people who are here. So we have traditional kind of biostatisticians. We have epidemiologists who have their own flavor of methodological expertise. We have individuals who are experts in clinical and bioinformatics. We have database designers, data managers, statistical programmers. And so we all can tap into each other's knowledge of these different realms. And just to name a few, not exhaustively, of our methodological areas of expertise, it spans omics, it spans a number of different methods that are relevant to clinical trials, so things like basket trials, early phase design, and sequential monitoring, survival analysis, adaptive design is in that first category as well, Bayesian methods, evidence synthesis, software development, machine learning, sequential causal inference, missing data, predictive modeling, epidemiology, and pragmatic trial design, just to name a few, and we're always bringing in new members who have additional sources of expertise as well. So something that we've been doing more of increasingly going forward that we're really excited about is to work on having stronger rigor and reproducibility policies and relevant mentoring, both, again, within our own unit and with our clinical and translational investigators. So what does it mean? Rigor and reproducibility can be thought of as a set of research practices, both in the implementation of a study and after the study is over, that aim to increase both its scientific credibility and its reproducibility. And the latter is referring to, we want to do science that is stable in the sense that if someone else tries to copy it, they're going to hopefully get the same-ish results. And it's not going to be something that is just a false positive. And so rigor and reproducibility practices are those that try to foster this type of scientific credibility. So we have a few sort of initiatives towards that end. So one is back to the idea of team science, having our members be included on, when it's a grant proposal, which it isn't always, but when it is, to be on that proposal for at least 10% FTE. Now, why is that rigor and reproducibility? Because the idea is to have us involved ideally as early as possible in the study and to be there through the planning phase as well as everything that follows, the interpretation of the results, the sharing of data and code when possible, things like that. We also do internal review of projects within QSU. So projects are either reviewed internally, either when they're a pre-submission manuscript or actually increasingly when they're in the statistical analysis plan or SAP phase. So meaning we come up with a plan for what we're going to do, and then we vet it with other QSU members to try to just get a second opinion. We also have a new initiative, which we're very excited about, such that all projects are pre-registered, at least by default. So what is pre-registration? You may be familiar with it from things like clinicaltrials.gov. This is a registration service where you can say, I plan to do a clinical trial. Here are my exposures, here are my outcomes, and I'm putting this out there so that I can't, down the line, change what the outcomes are. Pre-registration can be viewed as kind of clinicaltrials.gov on steroids, where it's not just listing your variables, but it's more detailed. It's actually saying, how am I going to do the analyses? What models am I going to fit? What will the primary and secondary analyses be? What will the sensitivity analyses be? And it's really good to think through these things together as a team at the outset of the project, ideally not once we already have data. Why? because we all have human, tendencies to perhaps like interpret findings in a way that maybe reflect our prior beliefs. And it's not necessarily intentional. It's just we all come to our research with certain priors and what we might get. And so deciding a priori how we're going to do the analyses can help safeguard against these types of threats to rigor and reproducibility. We also try to encourage individuals to engage with us quite early. So when it's a grant, ideally 3 months before the grant, or if it's not a grant, ideally as soon as you decide that you want to do a project. And that's again because we can really become involved with even the study design phase. And we do follow the standard ICM-JE guidelines for what constitutes authorship, and that's a discussion that would be had early on in the study as well. So this is primarily about QSU, but I do want to say a couple words about a separate center at Stanford, the Center for Open and Reproducible Science, or CORS, which is closely tied in with QSU and which shares a lot of its principles. So CORS started in 2020 and was initiated by Russ Paulbrick, who's a neuroscientist in the psych department, and I also co-lead it with him. And we had a couple of key missions. So the first is to develop resources and training that promote open science practices, first at Stanford and then moving outside our Stanford bubble, as well as to foster methodological innovations that can help enhance the adoption of open science, whether that be statistical methods or software or other forms of method development. And so we have a few kind of training materials that I thought I would just highlight here for this audience. So in particular, we have done a series of lectures, which are now posted on YouTube as a public resource. And the goal here is to walk folks through a number of key central reproducibility practices. So things like pre-registration or version control or reproducible manuscript writing. And to show you both an initial lecture that explains kind of the concept and why you might do this, and then have a second lecture, which is hands-on. How would you actually implement this in practice? So that's something you're certainly welcome to check out if it's of interest. We also have an annual meeting every May, which has some kind of open science related theme. So that's something that may be interesting to some of you. So I will leave it here. I think, do we have time for a couple? I don't even know if we can do questions with the. So I guess if you have a question, since most people are on Zoom, put it in the chat. Is that true, Neda? Okay. Yep. Okay, so that's not true. Okay, great. So I'm going to repeat that because I'm mic'd up. So we're going to actually save questions till the end. So please ignore this slide. And so next, we're really excited to have 2 individuals who have been with QSU for many, many deep partnerships and collaborations. And so we're going to have some really exciting case studies of how investigators have partnered with us. So next up is Suzan Carmichael. Thank you so much.
If I can figure this out. All right. Okay. Try not to trip. So is this is good? All right. Great. Well, thanks to everybody who's here and everybody who's online. Appreciate you being here today. So I'm going to give you a little bit of history of my work with the QSU, and then I'm going to talk in more depth about this particular grant, so we get that case study of how a project might unfold with them. Oops. Okay. So I was part of the Department of Pediatrics Research and Statistical Unit for several years, and this was a group of a small group of faculty and staff, and our main task was to really help people in pediatrics with their research with respect to analytic design, analytic approach, study design, and we also had some staff on board who could help do actual analyses. And I really enjoyed this work, got to know a lot of people over those years, and it was a step in the right direction, responding to a definite need, but it was kind of like a finger in the dike. The need was much greater than our bandwidth within that small unit, but it was a start. So in 2018, under Mary Leonard's leadership, we began this formal partnership between the QSU and MCHRI and Department of Pediatrics also being involved. And I don't think it's an exaggeration to say that it was basically that represented an exponential expansion of our ability to meet these research needs than we had been doing before. And so that's been really fun to watch that grow. I've been part of quarterly meetings since then where we, worked on just facilitating the transition, and we monitor who else being served, what are the projects that are being worked on in this partnership, and what's turning into new funding streams. And so that's been really, really fruitful. And also it's been fun to see the QSU has had enormous growth during that period as well. And then the other thing I wanted to note that I've been involved in, and it's related to that partnership, is that it involved recruiting a new faculty member. And I was on that search committee. And fortunately, we got Maya recruited out of that. So that was an amazing accomplishment, and has really helped be another piece of expanding that partnership. Okay, whoops, there. And then before I go into my actual grant, I wanted to highlight the first research project that I actually worked on in partnership with QSU, and it's called the Ananya program. And the PI of that is Gary Darmstadt. It was a Gates-funded program, and Gary was given funding to really evaluate it. And this was a really complex population scale, multifaceted set of interventions in Bihar, India, whose purpose was to improve reproductive and maternal and child health and nutrition. It involved a bunch of different organizations. It involved a lot of different types of interventions, one being, how do we administer some health education via cell phone that people had, or improving community health worker training and giving them technical tools to improve their work. There were self-help groups for pregnant people, media campaigns. So it was vast. And we partnered with the QSU, and mainly, I know there were a lot of people involved from the QSU, but the main ones I wound up working with were Isabel Wang, who I believe is still with the QSU, and Jason Bentley. And I just wanted to point out that I think some of the main ways that struck me in the way that working with the QSU was really important was we had this, crazy data from different organizations, different time periods and so forth. We needed to harmonize it and figure out how to operationalize the hypotheses we really wanted to test. So they really helped with the data management part, and also turning our questions into a reasonable statistical approach. And so another piece within that was really data visualization that really impressed me, because each question we asked, which there were many of them, had, at least there were 20 different outcomes that we really wanted to be able to tackle a lot in each, paper. And they really, really helped take that to another level. So that has stayed with me. So now I will talk about this. This grant is our sort of case study, and talk to you about how it developed. And as you were talking, Maya, I was thinking, oh, well, I guess maybe this one was chosen because we were collaborating from the very beginning. I know it's not always possible. It's what we aspire to, but this one definitely fits that. So speaking to that, so I'm going to tell you a little bit about the grant development. So it started in response to an RFA called Addressing Racial Disparities in Maternal Mortality and Morbidity. And it was posted on April 7th, 2020, and it was due May 29th, 2020. Yeah, right. So that was just a couple of weeks into the shutdown starting. So despite all of that chaos, somehow we rallied and got our team together and produced this. And then also May 25th is the day that George Floyd was killed. And so it's very memorable in that respect also, because I don't know about you guys, when you work on a grant, you kind of, I hibernate, I go into hibernation. I came out of hibernation those last few days and, went to the TV and was shocked. So it was easy to figure out our focus because we were responding to an RFA. So we wanted to look at the impact of social structural determinants on severe maternal morbidity, because that's the outcome we were focusing on. And then the next step was to figure out who's our team. And as I said a little while ago, this intersected with really, Maya had only been here for a matter of months at that time. And I knew about her deep expertise in causal inference methods. So I approached her and asked if she would be willing to collaborate with us. And thank goodness she said yes. So that was basically how our collaboration started. And then also wanted to talk about just sort of, you know, those general steps you go through in developing a grant proposal or any research project. You know, you've got your idea. We started there, started to think about hypotheses, study design, and statistical approach. And I put this graphic here because I just wanted to emphasize I put it in a linear way, but it is definitely an iterative process. And it's really, I love that process. You know, you keep, to get to the process of going back and forth between, well, we can do the statistical approach here, but really we need to change our hypothesis. And that's where, you know, it's great working with QSU. You roll up your sleeves and figure all that out. But basically, Maya led the writing of and development of the statistical approach, which was amazing. And I will say during the review process, nobody had any beef with the statistical approach. So, I mean, how often does that happen? It doesn't really happen in my world, but it did for this one. So I really appreciate that. However, they did have other criticisms. So we didn't make it into funding with the RFA, but we were able to turn around pretty quickly. We resubmitted in October of 2020, got one of those like almost scores, resubmitted July 2021, which I think, you know, part of this is just everybody, you know, reality check. This is like short time frame, but still it's long, right? Then we resubmitted, but fortunately the Institute's NIH decided to fund it. That July submission didn't get reviewed. So the October submission got funded, and funding started a couple of years ago. And thankful to the National Institute of Nursing Research for believing in this work. And then before I talk to you about actually what we were proposing to do, wanted to just give a recognition to all of our co-investigators. So the several people listed here at the top are all in leadership of perinatal quality collaboratives in Illinois, Louisiana, and then Elliott Maine also works with the collaborative here in California. And that is important to one of our aims, which I will tell you about in a minute. And then Maahs Mujahid is a social epidemiologist and an expert in place-based social determinants and health equity research. And then John Snowden is an expert in health equity research and also causal inference methods. Karen Phibbs is a health services researcher, and then we know Maya. And then also wanted to recognize there's a lot of trainees and staff working on the project, mainly between Stanford and UC Berkeley, but we're all a bit, it's all team science. I don't know what can be not team science at this point. And why are we focusing on severe maternal morbidity? Well, it stems from, we have a real problem with maternal mortality in this country. Basically, the US has a higher US maternal mortality rate than any other high income country. And this graph kind of illustrates that. You can't see the details, but just you can see where the USA is. Also, we're the only one where it's not declining. And if this is a good thing, most deaths are considered preventable through better care. So there's a way to do it, but we just need to do it. And then there's a big problem with disparities, especially across racial ethnic groups, with Black and Indigenous Americans being at highest risk. And this slide just gives a little bit more visuals to bring this home. On the left is 2020 births. Just again, there's a graphic. There's where we line up with the number of other higher income countries. And then 2021 births, seeing that the rates continue to increase in the last few years. And you can also see the disparities. That second group is showing the rates in non-Hispanic Blacks. And then why severe maternal morbidity? Well, if you think of, and what is it? If you think of maternal health outcomes on a sort of continuum of severity, maternal death is obviously at the top. And then severe maternal morbidity basically captures people who are most at risk of dying. It's a composite outcome that includes things like hemorrhage, eclampsia, sepsis, cardiovascular outcomes, and organ failure. But it has a very close connection to maternal death in that most people who who die related to pregnancy have severe maternal morbidity, and it's also increasing, also has the same disparities, and known high preventability through better care. And then here is the conceptual framework for what we're actually proposing to do. So we really want to understand what's the impact of social determinants on severe maternal morbidity and disparities in this outcome. And so we're really interested in those main effects to start with. And we focused on several different domains of social determinants: socioeconomic disadvantage, which might be things like neighborhood poverty; structural inequality, which might be things like segregation; community resources, which includes things like around the built environment; and then healthcare access, which would include things like, do you live in a maternity care desert? And those are multi-level. And then we are also really interested in understanding pathways. How do these things actually impact outcomes? And we're focusing on a couple of sort of buckets of health-related intermediaries. And one of them is hospital quality of care. And so one of the aims is looking at the impact of quality improvement initiatives on disparities in severe maternal morbidity. And so that's where my colleagues who are part of the different perinatal quality collaboratives in different states come into the collaboration. And then we're also interested in just physiologic vulnerability, such as hypertensive disorders of pregnancy and mode of birth, which would include, for example, overuse of cesarean birth among low-risk pregnancies. And so if you have a feel for our conceptual framework and where our aims lie here, and then just think about translating that to actual concrete analytic steps. And that's where Maya came in and really helped in that proposal and is our sort of our guidepost for moving forward. And then I want to spend a minute just telling you about the data that we're using, so you get a feel for that. We basically are using linked birth cohort files from multiple states, and there's a compendium of these that's being developed by Kieran Phibbs, who I mentioned earlier, and Scott Lorch at University of Pennsylvania, which is where these data reside. And basically what this consists of at its most basic form is that there's a linkage between birth and fetal death certificates with hospital discharge data, especially when we start with the delivery hospitalization. And from the discharge records, we can get codes that are used to characterize and capture people who have experienced severe maternal morbidity. And then the vital record really allows us to do population-based research, because that captures all births, and it also gives us a lot of different variables that are really important to this work. And then there's a whole bunch of layers of further linkages that we can do to expand how we use these data. And so I've put red arrows next to the ones that are particularly important to this work. So from the vital record or the birth certificate, we know where someone lived. And so that's how we can get information on place-based social structural determinants of health. And then we also know where they delivered, so we can get information about the hospital. And then we also link to beyond the delivery hospitalization to include antenatal and postpartum hospitalizations. And that's really important for SMM because close to 30% of all SMM cases happen after the delivery hospitalization. And then we also are able to link with the perinatal quality collaboratives and their activities. And now I just want to spend a few minutes highlighting work of specific people in the group. And the first thing I want to highlight is Eleni Hailu. She is a postdoc at UC Berkeley, and she did this work as part of her PhD dissertation at Berkeley. And I also want to recognize Maahs Mujahid, her primary mentor on this work. And so one of her papers is looking at racial ethnic disparities in SMM and intersectional life course approach. And what this graph shows us is, I know that it might be, some of it might be kind of small, but the basic gist is that she looked at basically the joint effects of maternal age, race, ethnicity, and some socioeconomic status related social determinants, and understanding how those things together, not just each thing in isolation, impacts risk. And here she used what we called the NDI as the socioeconomic, the social determinant indicator. And that is a composite of different neighborhood characteristics at the census level, things like neighborhood poverty and unemployment. And so if you go towards the right, that would be the most deprived or the worst off neighborhoods. So what we see here is we can see illustrated the disparities. We can see the increase in risk across age groups and also by NDI. And one thing that I think is interesting to note is that among, thinking about the life course, the older individuals, among the older individuals, the disparities seem to get even wider. And then I also wanted to highlight the work of Sang Gao, who also did this was part of her dissertation work at UC Berkeley with primary mentorship from Dr. Mujahid. And her dissertation focused on historical redlining, contemporary gentrification, and racial inequities in SMM. So this was really seen as, these are markers of structural racism. So they had institutional policies, economic development, and social marginalization. And thinking about how housing discrimination across generations can affect people's outcomes. Now, a lot of geospatial work in here that Singh is an expert in, a lot of mapping that was done. And then here is a brief results slide from her. Basically, she found that living in a historically redlined neighborhood was associated with 1.15, and then it should say 1.17, not 1.11, times the risk of SMM among Black and Hispanic birthing people. So if you lived in one of these redlined neighborhoods versus a not redlined neighborhood, risk was greater. Oops, went the wrong way. And then just a brief highlight of some other work that is most far along in the group. So Dr. Hailu has an IMPRESS article to look out for on neighborhood level fatal police violence and severe maternal morbidity. And then Marina Magalhaes is a postdoc in our group at Stanford, and she got a diversity supplement added to this grant to support her looking at SMM in particular among adolescents. And this is a particularly vulnerable group, given that we know that most pregnancies in this group are unintentional, and especially in the environment of sort of reproductive choice and abortion access and so forth, is especially impactful on this group. And then Veronica Gillespie, one of the co-investigators I mentioned earlier from Louisiana, she is doing leading an analysis looking specifically at SMM in Louisiana, and Shamali Bain has been instrumental in shepherding this work and conducting all the analyses. And Shamali is a PhD student in epidemiology here at Stanford. And so another paper she is doing, which Maya is a collaborator on, is a little bit more of a methodological paper, and it has to do with how we deal with people having repeat pregnancies. Whoops. Oh, switch soon. Okay, I'm almost out of time. I have like one more slide. Okay, so that's in progress. Just another example of how Maya has been brought in. And then our next step is basically to go back to our conceptual framework and dig into the middle more. That's our next step, and I'm done. Thank you. No, it's all right. No, you have to do that. You have to do that. Thank you. Great. So I leave that. Do nothing.
Thank you very much. All right. Well, thank you. Whoops. And then do I have to recalibrate the camera here? You'll do that. Okay. Let me see. Can you hear me now? Okay, great. And I got to push the button. Wait, this one? Whoops. All right. Great to see everyone and online as well. David Maahs, Peds Endo Chief, and I'm going to talk about data challenges and working with the QSU. We've got a study called the 4T trial, which I'll tell you about. But first, I'm going to go with that global theme that Suzan presented a little bit. There's an international diabetes registry, and it's predominantly in Europe, but we joined also one of the few centers in the US. And this is important because back in 2008, when we just joined it, we were on this end of the graph. And so each of these bars is a different clinic, individual clinic across the world. And this is the A1C, and you want your A1C lower. A1C is a marker of your average glucose in the last 3 months. So no one at Stanford likes being in the bottom quartile, do they? Right? So the first question was, do we have a problem here? Right? Can we possibly do better? And the answer, of course, was. Now, I will say that I know that we were doing better than the other clinics in the US, so made our people locally feel, okay, we're not doing as well as the rest of the world, but we're actually doing pretty well for the US. but we want to go down here. So this was the first slide that we kind of talked about as a team and said, hey, let's come up with some way to improve so that our patients are doing better. And a 0.5% improvement in hemoglobin A1C would be considered very clinically significant and have better long-term outcomes. So our division is very well known for doing artificial pancreas research or diabetes technology research. What this is, glucose sensors or a continuous glucose monitor. You might see those advertised. Nick Jonas advertises the Dexcom. The Libre is the other brand. They'll read your glucose value every 5 minutes. So instead of having to poke your finger if you're someone with type 1 diabetes 6 or 10 times a day, this is going to passively give you data every 5 minutes. It can also go up to the cloud, down to your parents' phone. So if you've got your child off at school, you can see what's going on with their glucose values. So that provides a lot more information, a lot more ability to have better control of your glucose. Insulin pumps have been out for about 30 plus years. And what the development has been in the last 10 to 15 years, in the last, say, 3 to 5 years clinically, is that you can now beam that information from the glucose sensor to the pump. The pump has an algorithm that can modulate insulin. If it predicts you're going to go low in 30 minutes, it can stop delivery of insulin. And if you're starting to go high, it can give a little bit more insulin. You still have to give a dose before you eat because insulin takes about 15 minutes to start working as its peak effect in about 90 minutes. So this is the background. This is what's happening nationally and internationally with advances in care. What we did then as a first step was take a look at what were we doing in the first 18 months after diagnosis. And these are patients in our clinic from 2014 to 16 who had been diagnosed with type 1 diabetes. And at the beginning, they don't know they have diabetes, so their A1C is elevated at diagnosis, that 10 or so. And then as you begin treatment, the A1C and average glucose comes down around 4 to 6 months. You have a nadir. And then there are physiologic processes where those remaining beta cells are not making as much insulin. And the glucose values kind of creep up and kind of stay there. So the idea was, can we do some sort of intervention to prevent that A1C from creeping up after the 4 to 6 month period? So we came up with this plan, teamwork very clearly being the first T, targets to have tighter glucose targets for people, technology. We made it so that everyone could get a continuous glucose monitor in the first month. Typically, it was in the first week. And I'll show you some data on that, as we wanted to make sure this was equitably delivered so that everyone in our clinic got it, whether you had public insurance, private insurance, whether you speak Spanish, whether you speak English. Second, in addition to reducing that trajectory, people who have type 1 diabetes are more than just glucose values. Patient-reported outcomes are really important. So what sort of quality of life are they having? And then third, we worked with our engineering team to try to develop an automated system to take that data, put it in a format, put it in a dashboard so that our diabetes educators could more efficiently use the data and figure out who amongst our patients needed help, which families needed help at what time, so that we could reach them a little bit more frequently than every 3-month visits that we typically have. And on with the theme of involving the QSU early, this first paper just describing what our historic cohort looked like. Manisha and Jaden from the QSU were part of that. So I should have had a slide like Suzan did on, we also got rejected the first time we put in a grant. That's how it goes. And then we revised it and did get funded. There we go. So, whoops, go back here. So this is David Schenker. He's has a group called SURF that he manages, a kind of a quality process improvement. And this is a paper that we put together with Rick Majan, who's our COO at the hospital. And conceptually, the idea is, historically, we would see patients every 3 months. So you'd miss opportunities to intervene when these average glucose values start drifting up slowly. And then maybe you'd see them in clinic, change doses around, provide some education, get better for a while, and then things would drift again. And so the idea was, if we can detect this deteriorating control, can we intervene in a more timely fashion and be able to keep the average glucose in a target range? So kind of another way of thinking about it is with these CGMs, BlueView was an initial iteration of the system we used to get the data in to the electronic medical record. Our CDEs are able to use things in a more efficient way, be able to reach out to the families, not in real time, but in a more timely way. And then that leads to a reduction in hemoglobin A1C, more time and range, that goal range is 70 to 180, improved quality of life, and then also to reduce hypoglycemia. So there we go. So the team came up with this system, David in the lead, and Priya Prahalad, who's one of our peds endos and also IT certified or boarded, came up with this dashboard called Timely Intervention for Diabetes Excellence. And this is one picture of what it looks like in their publication. Johannes is a graduate student, PhD candidate with them. And so basically just looking at some simple metrics, what percent time were people wearing their CGM? If they're not wearing it, then that often indicated that insurance had lapsed or there was some sort of problem with supplies, so we could reach out on that. What was their average glucose, time in range, time low? So very simple metrics, and then you could rank who needed your attention. If everything's going fine, you don't even need to go then and look at the numbers, but you could then rank who were the top people, drill down and get more information, and be able to reach out to the families. So as far as the methods, I'll show you some data. Everyone was offered the opportunity to start. Very important to the team that this was an equitable study, that everyone had the opportunity for it. We came up with a way to use, to get CGMs to people early, both with a combination of philanthropy, then advocating for Medi-Cal to be able to provide this to all children. And then with the research grant. Then we had an added visit with the nurse practitioner to follow up by telehealth, having this weekly CGM review then by our diabetes educator team. We also had the patient-reported outcomes. I'll show you one slide on focus groups because we were trying to make sure that what we thought was working, that the families and children thought it was working as well. And then it was very much an iterative work with the engineering team and the clinical team on the TIDE dashboard. So the statistical analysis, I'll show you, we look at those A1C trajectories, comparing back to the pilot cohort, and then did low space differences calculated at every 3 months after diagnosis. So these are the findings. So the red line was that version of that graph that I showed you from the historic cohort. You know, again, we've got month 0 to month 12, the A1Cs on the left, and then the dotted line was that goal of 7%. In the first iteration, the pilot study that we did, we got about a 0.5% reduction in A1C at 12 months. And then with the study 1 that we just have submitted these data in review, we got about a 1% reduction. Another way of looking at it is we went from about 25% reaching the target, and actually that's the next slide. Oops, not quite yet. Another way of looking at it is just what do the CGM data show in addition to that A1C blood test, and we're having about 67% in range. A little bit of a decline, but it's a lot less than what we'd seen before. And also important that we have very, very little hypoglycemia. Less than 4% is the goal, and we had about 2%. Then looking at it categorically, this is the point I was making, that we had about 28% who were reaching 7% back in the historical cohort, and we're up to 64% now. So that's wonderful. Talked a little bit about trying to do this in an equitable way. This is a nice paper by Anant Adela that just came out in JAMA Network a few months ago. And the point of this is that whether you were Hispanic or non-Hispanic in the graph on the left versus private or public insurance, everyone got a similar benefit. The second point so we delivered it in an equitable way so that everyone benefited from it. Often if you introduce technology, you can widen disparities because some people get it and some people don't. Everyone benefited, and also there are still gaps in how people do, whether they have public and private or whether they're Hispanic or non-Hispanic. So still more to work on, but everyone benefited from the intervention that we had. Ananta and Desi, one of our instructors, have a grant with the Helmsley Charitable Trust to look more into this as well. I talked about the focus groups. I think it was Molly Tannenbaum and Corey Hood, psychologists, and I love this quote. I was ready for it at the beginning. So it was a question of, should you wait to give a continuous glucose monitor to a family after diagnosis because they're going to be overwhelmed with all of the data? And in fact, families said, no, actually, we would like to know what's going on with our child and to have that information. And then I mentioned Desi. She's a PhD in exercise physiology with a focus in diabetes. And again, to think about all the data that's flowing into the QSU and into the system. We also have exercise trackers on a subset of patients. So has everyone seen accelerometry data before? Maya's nodding her head. So it's even messier, I would say, than the CGM data, where you have 288 glucose readings every day, now in about 400 kids. So think about, do that multiplication of how many glucose points we have, and then how do you then add in the exercise data. There's really no data on a standardized approach to exercise in people with type 1 diabetes. So very interesting just to get the data, but also that the education that modules that she's providing seem to have a benefit in increase in exercise, that the step count increases. And exercise can be a real challenge for children with type 1 diabetes. They want to go out and play soccer, play on the playground, whatever. If you're worried about having a hypoglycemic event, that can cause a lot of worry for parents and problems potentially if you don't give that education. And then just another slide showing that the moderate to vigorous physical activity also increased over time. And that the time in range stayed high in this subset of patients. All right. There we go. So back to that first slide. So we were over here. We're finally into the green. There's no way we're ever going to be able to compete with the clinic of 150 in Sweden, who are the ones way over there on the left. They're able to they've got artificial pancreas systems sitting in the hospital. You get admitted, they put it on you right away. So it's like and they've got their ratio of docs and nurses to patients is really low. So we'll keep trying, but I don't know that we're ever going to catch those groups. But we're now less than 7.5 for our whole clinic, and we'd like to get down to 7, which we think is achievable in the next few years. So lots that we need to do. We're up to about 400 patients who this program reaches in our clinic. We've got about 1,000, so we're slowly rolling that out. We've got another 1.5 years or so on our R18 grant, and hoping to then be able to, we're working on the last cohort will be a sustainability cohort, and that's something we're talking to the QSU about. It's like, how do we continue to do this when we don't have that level of funding that you get on an R? We also have a dissemination and implementation grant that will get reviewed next week to take this program, adapt it to a clinic in Kansas City, Children's Mercy Hospital. And then the next steps after that would be, how do we take it and then disseminate it, scale it up to more clinics across the US. So that's some of where we're trying to go, and lots of people to thank. We've got Manisha in there. We've got lots of peds endos, psychologists, management scientists, exercise physiologists, computer scientists, lots of people who have contributed to this work. We also NIH grant, the Helmsley Charitable Trust has funded the exercise study. The Diabetes Research Center has provided support, the Packard Auxiliaries. MCHRI has an NSF grant. And then we've been fortunate also to have a Stanford Human-Centered Artificial Intelligence grant that Carlos Guestrin and Emily Fox are the leads on. And then MCHRI also has provided funding for us. So I will stop there and thank everyone for their attention. And I think we've got Q&A here, but Mary's going to come lead the way.
Okay. Any questions from the live audience? That was a terrific series of talks. I really like having the case studies showing how you collaborated with the QSU. There are a couple of. Yeah, okay. You have a question?
So I do preclinical research, mouse studies, and I've always thought that the kind of thing that I do is sort of too simple, but QSU, and I just want to ask if it is, we have in vivo studies, planning, behavioral studies, et cetera, that does require some basic statistical analysis that I'm never quite sure about. And that was the first part of the question. The second part is, you talked a little bit about data management and storage, and so we're all dealing with the data plans that for all our grants, NIH grants, STRM grants, et cetera. And if I'm wondering about university resources that can help kind of streamline data management and storage.
Yeah, these are great questions. Thank you. So I think definitely no lower or upper bar for how complicated is not complicated enough or too complicated. And I do think often something maybe seems superficially less complicated than it actually is. Sometimes the study design is simple, but the stats are not necessarily simple. Or even if the stats are simple, maybe the interpretation is nuanced. Maybe it's all straightforward, but we can still, still very happy to help with that. Yeah, and then to the new NIH requirements, yeah, this is something we're very excited about. We do think it's a real step forward. So that's something we can certainly help with on the planning side, the grant proposal stage, as well as the actual, how do you follow through on that? And then I think the core's resources may also be useful on the latter point in terms of sort of some relatively standardized lectures around how you might do these practices. We also have an open access guidebook that's kind of designed for Stanford investigators, regardless of their discipline, that may be helpful with some of those requirements as well.
Hey, I'm just going to read off some questions in the chat. What would be the cost or change in culture to improve, deliver the DM care in clinical practice? Feasibility to translate into clinical care? Not sure if I don't know, Ron, if you want to unmute yourself and ask the question.
So it sounds like, how do we change? Is that like a change? Yeah,
go ahead, Ron.
We'll go with that. So I think.
Hi, David. It's just a simple question. Translating it, I know you're looking at it as part of your research, but really, what is the cost and the potential for actually changing clinical practice? What is the feasibility?
Yeah, that's a great question, and that's what we're working on right now. Two very clear barriers to taking this elsewhere. And even for that matter, sustaining it at Stanford. The first is the TIDE dashboard has been developed and supported by graduate students. That's not a sustainable way to do it, but we're partnering with a nonprofit diabetes data aggregator system that they're actually based out of Palo Alto called Tide Pool. They reach about, I think they're up to about 500,000 people whose data flows in through that. They work with clinics. So we are, in the next couple of months, we're going to transition from the way we've done it to using Tide Pool. That'll take a little bit of time as we have to get all the participants registered with that. But that's one issue. The second issue is we've been able to support this and develop this with research grant money. But how do we sustain this? There are codes that you can bill for remote patient monitoring. A few challenges with that. One is not everyone insurance is going to cover that, but you have to be equitable. Yeah, you have to charge everyone. You can't charge just people with insurance. So we are doing a pilot to try to figure out, and this has been in the works, figure out what % of people get a copay for a weekly. If we do a weekly, well, we are doing the monthly reviews of the data. But if we then try to bill for it, how many people get a copay for that? If you get a copay for that, you might get irritated and say, I don't want to be part of your program because you're charging me $10 a month or whatever it is. So we got to figure out what percentage that is. We do have some philanthropy to fill that gap in for the pilot. So if somebody is getting a bill, they can't cover it, we've got funds to do it while we're trying to figure out how to scale this up. And then the question is, how much funds will that bring in versus how much philanthropy we need to get to support it? But if we don't have some way for paying this, we are doing extra work. We are getting better outcomes. We do have families saying they prefer it, but how do we get paid for it? And pediatric diabetes has not figured this out. And we've had the ability to do this for a long time, so it's a national challenge. But those are two things that we have to do to scale. I would say the third is maybe a more general clinical medicine challenge of it's hard for us to change how we deliver care as both as systems and as individual providers. So it's hard for us to change. So that's why I started with that slide of we're way down on the wrong side of the graph. And are we happy about that? If everyone's fine with how you're doing in your clinic, then stop, right? You're not going to change anything. But most people are going to see a slide like that and say, no, actually, we don't want to be there. Let's improve. And then you have to have that conversation about how we're going to do it. Because it can't be me telling you how to do it. It's like it has to be our vision of how we're going to improve things. Anyway, long answer there.
You got a thumbs up.
I apologize if I missed this, but how do we reach out to the QSU? Do you guys have an intake process if we have studies to explore?
Yeah, thanks for asking that. We do. So we have a few different inroads to the QSU. The most straightforward is probably just to go on our website, and there's something called a project initiation form, and you're just going to answer some questions about your study. Is it a grant? Is it already funded, not funded? What are you, trying to look at? What statistical needs do you have? And that puts you in our queue to get back to you. And usually we start with a kind of initial intake meeting to learn a little bit more, and then figure out how best to pair you up with one of our QSU members. Another thing that's also available to MCHRI members is we do hold regular office hours. That's usually going to be me, sometimes also another QSU member. And this is especially towards grant deadlines, so the internal MCHRI award series. And so this is for you all to come and have a shorter term, consultation to talk about your needs for the grant, which very often does then turn into a longer term QSU partnership upon funding. So those would be the two main roads I would suggest. That's right. Yeah. The project initiation form is, and the office hours are circulated about quarterly when they happen by email.
Okay. So I'm told we are at time. So thank you very much, everyone online and also here joining us in person. And we hope to see you next time. Thank you so much to all of our speakers today. And thank you. Okay.
Thank you so much.